analyst, so the full spectrum of cardiology. And today, unfortunately, I have the long topic according to time, because I need to discuss all those indications which were looking as the simple task, but looks like more complex in interventional cardiology. First of all, the very popular concept which we saw in the first slide on your center, that you have like around 10%, when I calculated, yes, 10% of DCB in your center in comparison to PCI. So it looks that people want to leave nothing behind. This is the story which we know from the bioresorbable stents, and wanted to have the artery PCI stenting without any metal. However, we have some problems with the technology. However, the bioresorbable stents are coming back, but looks like that DCB are faster in terms of the leaving nothing behind. Why we are so focused nowadays on DCB? Because we want to deliver antiproliferative drug without any implant. We can preserve vasomotion and vessel physiology, which was all the time the target for us. We want to avoid the stent thrombosis because there will be no stent, and no atherosclerosis proliferation after the DES in the long term. So we know that this metal burden has impact, and it could occur in 2% per year with the difficulties with the drug-eluting stents. So that's why we want to eliminate this risk with the new concept. So on the left, I have the, let's say, so well common known DCB indication like in-stent restenosis and small vessel disease, and majority of people, they agree that they could use DCB for this indication. However, according to the title of the lecture, when you go in more data, you have more evidence now with de novo coronary lesion, with bifurcation PCI, with long lesion, large vessel, with CTO. So there is growing evidence that DCB are not only for this in-stent restenosis small vessel disease. So that's why you cannot see only 10% of the penetration in some cath labs, but we see the cath labs when have the 20-30% of PCI with the DCB, so it's much longer, it depends on adoption. What is very interesting is a story 2018-2024, and the left after this 2024. In 2018, in guidelines, it was clear said that drug-eluting balloons are for treatment of in-stent restenosis with 1A indication. It was clear. And drug-eluting balloons could be used for the disease progression and late graft failure, and in-stent restenosis BMS or DES 1A indication. And it was clear for all people that we can use the DCB. Then it was the change in 2024. Then it was the downgrade of for in-stent restenosis, and the DES were more recommended than DCB. Moreover, if we go for the de novo lesions, in the first guidelines there were no formal guidance, and for the newer guidelines it was also no recommendation. DES is the standard of care. When you compare the acute coronary syndromes, is a marginal role mentioned in the guidelines, the 2024. So let's say that it should be stopped the story with DCB. However, after this 2024, we see completely opposite, because we see more and more use of DCB, and people are more convinced not only for in-stent restenosis, but for many different indications. So here, that's why after this 2024, you see the consensus document Eurointervention 2025, when the researchers, with the lead of Patrick Sirois and Yoshi Onuma, they decided that it's not so easy to really check the study on DCB in comparison to DES, because you need to consider the type of the clinical study, endpoints, statistical method, and you need to differentiate different lesions and not only in-stent restenosis or small vessels. So that's much more complicated. And consensus document was saying that we should go in the different way, and you should be more open for the new indication. Of course, with the recent publications you have after this 2024, of course there are some limitations, and of course it could be some failure of the DCB, patient-related, lesion-related, procedural-related, and biologically mechanism, a lot of problems, but in general we see that in new publication following 2024, you have more and more evidence with the different indication. Number one, in-stent restenosis, new studies which are after 2024. You see that in this study for in-stent restenosis, sirolimus depth is non-inferior to usual care, mostly DES, usually it is majority of this, but inferior to DS as a single layer in-stent restenosis, okay? So it could be justified that guidelines mentioned in this. However, if you compare to the standard care with DCB, you are good. When you look for the very interesting approaches, some researchers even double DCB. They use the paclitaxel and sirolimus as a second DCB for in-stent restenosis with good imaging. Also, some researchers from Asia are brave, to go with this new concept of in-stent restenosis with two DCB techniques. When you go to reform study, again 2025, so following 2024, you see that there is no difference between the different technology for in-stent restenosis. So looks like that the evidence is growing for in-stent restenosis towards the DCB. Another indication, small vessel disease. There are again new studies which are saying about the role of the DCB in small vessel disease. This was the study with bailout stenting. So in conclusion, it was that DCB only show better one-year outcome than bailout stenting. So it means that if you go with the DCB, it's better that you do additional stenting. Restored as small vessel disease China randomized trial, which was before, but showing the non-inferior result of DCB in comparison to DS. So we should remember there is a well-established indication for small vessel disease. And as well in Picoletto randomized clinical trial, even DCB was superior to everolimus eluting stents. So again, we have the good evidence. When we go the de novo lesion small vessel disease, another study 2025, we see that DCB are safe and effective for de novo lesion, and we can show the promising result in the target lesion revascularization for small vessel as side branch disease. So new study which is showing again that if you go for the small vessel and de novo lesion, you can achieve the good results. Then people are thinking, okay, if in-stent restenosis and small vessel disease is not enough, so let's go to large vessels. And again, we have the new evidence, which I remind you that the guidelines are silent on this. And 2025, you have the comparison of the drug-eluting balloon versus DS of meta-analysis, and we see that it could be even in favor of drug-eluting balloon. And it's a small signal for higher rate of myocardial infarction, which is non-significant here, but in some studies we see clearly that the risk of stenting could be associated with more myocardial infarction, and the cardiac deaths were neutral. When we go to another study with the small vessel disease, and the comparison, we see that in general it is non-inferior. Only the REC cage fire was not good enough to show the DCB strategy is good, but all other studies and meta-analyses are showing that we can achieve the comparable result of DCB versus stenting. When we go to next indication, which is bifurcation lesion, again, new publications following 2024, and we see that people love to do the stent to the main vessel and side branch. When you go to the side branch with the regular balloon, you can have the good result, but with DCB probably better. Also, we have the combination for bifurcation or in general for the hybrid approach of using of DES and DCB strategy in some vessels, long lesions or bifurcation. And it could be safe and feasible, and today I'm sure that there will be a lot of discussion and today and tomorrow on this indication of hybrid approach DES and DCB strategy. When we look for the DCB bifurcation trial, we see that in simple true bifurcation, DCB for compromised side branch after main vessel stenting was reduced, and early periprocedural MI rates were high, but clinically unclear. So there are some confusions, but in general, stenting the main vessel and ballooning with DCB the side branch looks as a very interesting strategy. So this is another study that provisional DIEB is the first randomized multicenter non-inferior trial comparing one stent and DCB versus planned two stent in true bifurcation lesion. And this is another study, another example of this strategy to just implant the stent to the main vessel, do the ballooning, and not to put the two stents. Even some researchers are so brave that they go to bifurcation left main. So to left main, there is no big number, only less than 50 patients in each arm. However, they are saying that there are basically no differences in DCB and DES. We are not so probably brave to do the left main, but some occasions and in some particular indication, I would say that could be considered. And they are showing that there is no difference, but I remind you, this is a small study and some experience with Asia. Concerning the long and diffuse disease, we have again the evidence from 2022, 2026, that you have basically no differences for diffuse coronary artery when you compare the DCB only, and here it was the combination of DCB and DES, and in the newest approaches, also the patients with another indication, which are HBR, high bleeding risk patients, are also considered for the DCB. Why? Because after DS you need the prolonged dual antiplatelet therapy, but there are sometimes the concerns that you can not use long dual antiplatelet therapy, especially with anticoagulation as a triple therapy. This is a case showing that patient was permanent anticoagulation with warfarin, and researcher decided to use the imaging with Emmanuel is a topic for today to show the perfect imaging with DCB strategy to avoid stenting, to have the shortened antiplatelet therapy. Another study for de novo coronary lesion with high bleeding risk, and we see that the DCB only PCI was superior to bare metal stent. This is the old study when people were not so sure that they can use DES, but DCB in the past were better than bare metal stents. So another signal that if you want to decrease the dual antiplatelet therapy, it makes sense. But let's go with this to newer study, the Sweetheart Registry, and some systematic review of meta-analysis, so the only new studies I am targeting. So in the systematic review of meta-analysis, we see that no statistical difference in clinical and geographical outcome between DCB and DES in acute myocardial infarction. So even if you go with DCB with strategy, and people are more and more brave with the strategy of acute MI, so you can see that there are basically no differences. When you have another study on the drug DCB, in this study also in DCB was non-inferior to DES for primary PCI, so another new evidence after 2024 that we can have this approach. Very interesting sub-analysis of the Sweetheart Registry, well known, with abbreviated DAPT therapy and standard DAPT better. The standard was 12 months after the acute coronary syndrome, but in abbreviated it was less than 6 months, usually 1 to 3 months of dual antiplatelet therapy when DCB were used. And you see non-inferior results. Of course, you should remember about the progression of coronary artery disease and the risk. However, you see clearly that there was no difference in the shortening dual antiplatelet therapy with this strategy. And finally, the recent piece of evidence, so the last TCT, ACC, and the PCR. So we have the solution de novo trial, so de novo lesion, again, very strong new indication. Then we have the basketball study, which is ongoing study to show that really new approach with DCB could be equal or even superior to regular drug-eluting stents. We have the bifurcation focus with the imaging, which is very important, and Manuel will describe today a lot on this. And also, as you see, that people with bifurcation club also are very focused on this strategy. So with the de novo clinical trial solution, we see that quite big study recently presented, and we see again no difference for this strategy of using DCB versus the drug-eluting stents. And as I mentioned, when you look for DS strategy, you have a clear signal for the myocardial infarction. Of course, with target lesion vascularization sometimes could be opposite. However, the signal is to be considered, especially when you don't want to lose the side branches and you have difficulties. Another, the evidence 2026, just 1 month ago, even a few weeks ago, that basket pivotal non-inferiority strategy that will test the sequent balloon against the modern DS in clinical and anatomical high-risk indications. So a lot of big group, a lot of countries, and again the brave approach not only to go for the easy lesion but high clinical risk and high anatomical risk, including multi-vessel, long lesion, calcification, and bifurcation. Finally, we see the DCB approach with this strategy of stenting the main vessel versus the 2 vessels, and you have the different approaches. With the main vessel, you need on the result to stent 1 or 2, but basically to stent the 1 stent and do the ballooning of another. Also the huge focus of European Bifurcation Club with the DCB. The topic of the imaging, the new studies are showing that the lead loss with the DCB group in the side branch is less than if you do the regular ballooning. So if you consider do balloon, so better take the drug-eluting balloon DCB than balloon, because it will be better for the preservation of the lumen of the bifurcation. And the final ISR clinical trial, the study which was presented PCR TCT, that was including patients for in-stent restenosis with the very good protocol. And we see that this is the study which is first time showing that DCB is non-inferior against the standard therapy, including 80% of drug-eluting stents. So we have the new evidence 2026 that really in-stent restenosis, and this mentioned in guidelines that only DS should be superior, I think is any longer valid, because we see with the new evidence that DCB really could be non-inferior to drug-eluting stents. And also the chronic total occlusion, the CTO club, they are going with the registry, and they did the sub-analysis of the registry, and they are showing that they raised the use of DCB 3.5 to 15%, so increasing the number of the use of DCB. And if they did the comparable analysis according to the DS, they see that is a lower contrast use and lower stent length for patients which are with DCB. Not everything is perfect, and the cage fire trial mentioned by me was not so good for DCB according to DS. However, the comments are that different technology of DCB could be used, so it's important which DCB used in terms of the drug and the delivery system. And of course, this is the other investigation. However, sometimes are not perfect results. So a lot of studies, as you see, with the newest publication, and my last point, the future perspective, what are the future perspective? And in this publication, we see the clear future perspective 2026. Long lesions, yes, because you can eliminate side branch loss, stent length, you can decrease and facilitate of the future intervention. Bifurcation lesion important because you can have the better geometry in terms of the carina shift and patency of the side branch without stent scaffolding, which I mentioned a few times today. CTO, people, they like, the CTO club, they like because they have no problem with malaposis and expansion and lower contrast use, and this distance of the stents, the length of the stent is shorter. Calcified lesion because you can avoid sometimes the problem with the stent eccentricity and disease landing zone, especially when it's not well prepared vessel. Some people see in acute MI the potential role of DCB, and they want to avoid the stent implantation in young patients. They want to avoid the risk of stent undersizing, and as I mentioned, you can decrease in some situations DAPT therapy and not necessarily use 12 months if you can. High bleeding risk, more or less the same regimen that you can shorten the DAPT therapy, dual antiplatelet therapy, and also you can switch easier, faster to single antiplatelet therapy. And some people see that maybe diabetes mellitus with the long lesion and maybe probably this combined approach of DES in more proximal and DCB in the distal part of the vessel also could be a concern. So in this publication, future perspective, and I agree fully with this, what we can summarize, in-stent restenosis, proven therapy, looks like. De novo lesions, reliable option. Large vessels, selective use, yes. Bifurcation, geometry preserving, and the side branch with DCB. Long diffuse lesion, metal sparing. High bleeding risk patients, ideal candidates when you need to avoid the triple, especially therapy on long dual antiplatelet therapy. ACS, people are slowly going in this field as well. So in summary, I would say that the limitation of DCB require excellent lesion preparation, operator experience. It will be a lot of today in the discussion and in the next talks. You can avoid the recoil and dissections by bailout DS if you really need. We have no full evidence. I presented the study 2025-2026, but we need probably with the studies with longer follow-up. But I would say that in 2026 we can say that less metal, more drug, and more physiology. I think that all of us agree. So old model, stand everything, full metal jacket. New model, lesion-based strategy. DCB, if good lesion preparation, acceptable result after ballooning, fine. DS only if you have the recoil, the strong recoil and flow limiting dissection. Of course, you have to do DS, which is no more than, I would say, around 10% of intervention. So finally, I would say DS is the most important innovation right now in coronary PCI, non-inferior to DS in selected cases. That would be the topic of our workshop. Real possibility of the stent-free PCI, because we have no perfect drug bioresorbable new bioresorbable stents. We are waiting, and the DCB are improving and progressing much faster. So I would say that this is the conclusion that is becoming a core tool in modern interventional cardiology. Thank you. It was not easy to go through all this. I was really scared with checking the title of my presentation. But looks like that's really increasing the indications.